alluded to about obesity, what are the pathophysiological mechanisms, and how best we can tackle it. We still don't have the answer actually, but yes, we are trying our level best to tackle it with lifestyle, with medications. So I'll be also now discussing one of the medications which she already talked about, that is Tirzepatide. So how do we tackle this epidemic with this medication, and what is the evidence we have? So this is the disclaimer for this program. This is my disclosure for this talk. So when we talk about Tirzepatide, we know that all of us have been using Tirzepatide for quite some time now, and we know that it is a GLP-1 plus GIP. So we know that it has these two by which we get, or by how we target the obesity. And we know that GIP is a nutrient-stimulated hormone, and we know it has multiple sites of action. So not only does it has an incretin effect, but it also helps in the secretion of glucagon. So we know it has also an action on the alpha cells of the pancreas. Also, by this and the other mechanisms, there is also an inhibition of food intake. It has a neuroprotective effect also. We know that there is data coming up with that as well in neurological diseases as well. And also, it has an action on the insulin-dependent fatty acid uptake and mobilization. It increases the adipose and the splanchnic blood flow as well on the vasculature. So it has multiple mechanisms, just doesn't have one. But we know that what we are targeting are the first two, which are more important, and also the others as well. That's how the role of this in prevention of cardiovascular and renal and other things also come up. And we also know that it is an important regulator of the lipid metabolism. So when we talk about the use of the GIP in the adipose tissue, we know that it increases the glucose and the lipid uptake into the adipocytes in an insulin-dependent manner. It also increases the adipose tissue blood flow in an insulin-dependent manner. And under the fasting conditions, it mobilizes the lipids from the adipocytes, which allowing the utilization in the adipose and the non-adipose tissue as well. And also, when we talk about a co-agonist of GLP-1 and the GIP, we know that this is what we are talking about today. It shows greater improvement in the postprandial lipid metabolism as well. So it increases the fatty acid oxidation as well. So this is a little bit of the theory we learnt about, because we need to understand how it works, and then only we can understand that how best we can put it for our patients or use it for our patients. And we know that if you talk about Tirzepatide, it is designed to activate both the GIP and the GLP-1 receptor, and it is based on the native GIP sequence only. The half-life is approximately 5 days, and that's why we use once a week dose. And that's why we know that the dose adjustment is not recommended for patients who have renal or hepatic impairment, so we can use the same dose. Now, when we talk about the biological adaptations, which we learned in the previous speaker talk, we know that this agonism actually reduces the appetite and the calorie intake. Also, it has an agonism in the adipocytes as well. It regulates the glucose uptake as well as modulates the lipid uptake. This is what we learned. And that is how it helps in reducing the body weight as well, and results in a greater fat mass loss than the lean mass loss. So what are the approved indications? We know that it is definitely approved for use in diabetes. So you can use it for your patients as an adjunct to lifestyle modification, diet, exercise, and this medication with other drugs as well. For chronic weight management is the other approved indication which we have. So you can use it in patients for chronic weight management with BMI more than 30, or if they have other at least one weight-related comorbidity, then you can use it above BMI of 27 as well, which includes hypertension as well, and we know diabetes, dyslipidemia. OSA is one major indication where we are using it in a lot of our obese patients and cardiovascular disease as well. So let us have a brief overview about the SURPASS trial. So what all we have learned from the different trials. So whenever a new drug comes, or whenever we try to see the efficacy or the action of any drug, we try to compare it with other medications which we think could also have the similar effect, or we try to see whether it is better or same, or it works better, or what happens. So there was obviously one with placebo, then with semaglutide, then with insulin degludec comparison, then glargine, and then as an add-on to insulin, and as an add-on to insulin glargine with or without metformin. So they have tried to see, and most of the studies have been done over a period of 8 to 10 years to 11 years. And what they have clearly found out that if you see for the weight management, they have definitely shown beneficial effect. They have tried to see for type 2 and weight management. They have tried to see in weight management with intensive lifestyle as an add-on to this. For the weight reduction maintenance, they have tried to see in the SURMOUNT-4 and in the SURMOUNT-5 weight reduction compared to semaglutide they have tried to see. So if you come to the SURMOUNT-1, it investigated all the dosages. We know we start off with 2.5, then we go on escalating every week the tirzepatide by 2.5, so we go to 5 to then 7.5 to 10 and 15. And they have tried to see this, the effect of the dosages of 5, 10 and 15 in versus placebo in adults who were overweight or obese with complications excluding type 2. So this is what they tried. This was a phase 3 study, and definitely they were trying to see the weight change and the percentage of the population who has achieved that. So the most important thing was the weight reduction was seen as soon as 4 weeks. And this is what we have seen in our practice as well, because now we have been using it for quite some time and we were part of trials as well. So what we have seen that the weight reduction is seen very early, and the powerful weight reduction was seen at 72 weeks, and the average was 16%, because many times the patients will ask, how much percentage I lose? So that's the average which was seen with tirzepatide 5 mg at 72 weeks, and 22.5 was the average with 15 mg at 72 weeks. And the majority of these patients with obesity achieved more than equal to 10% weight loss, because whenever we talk about diabetes or talk about diabetes with obesity or obesity management, we talk in terms of percentage. We don't say that patient will lose 2 kg, 1 kg, 5 kg. It's not like that. It's a percentage weight loss, because we have clear-cut data that this percentage weight loss translates into reduction of the metabolic problems. This percentage weight loss translates into MAFLD and MASLD reduction. This percentage weight loss, finally 15% and more, will translate into cardiovascular risk reduction. So this is how we count the percentage weight loss. We don't say that it's 2 kg will translate to this. So it's not like that. And that's the reason if you see most of the weight loss studies have tried to see the percentage, not the absolute one. So they found that majority of these patients at least achieved more than equal to 10% weight loss with tirzepatide 5 mg, and 2/3 of the patients who were on tirzepatide 15 mg actually experienced more than 20% weight loss as well. Now the other important thing which comes to the thing is the changes in the body composition, because we know that until unless we see that what exactly is the cause of the weight loss. So that's important. And they found, when they did the DEXA study, to see the changes in the body composition, they found that there was a reduction in the fat tissue, including the visceral fat. So what they found that the patients lost visceral fat. So this is important, because if the patient loses muscle, a diabetic patient who is uncontrolled is also losing weight, but that patient is losing more of muscle mass. So we are not targeting that type of a weight loss. We call it as an unhealthy weight loss. We are targeting a healthy weight loss, and that is what was seen. Also, this is the most important thing, because why we are treating diabetes, just not for glucocentric approach or weight loss approach, we are treating diabetes for the cardio-renal, metabolic, hepatobiliary risk reduction. That is the purpose of treatment. And that is what we are trying to see. So what they found that people who were taking Mounjaro actually experienced improvement in the cardiometabolic parameters at 72 weeks. There was a reduction in the systolic blood pressure by 7 to 8, diastolic by 4.6 to 5.5, and also triglycerides reduced by 24 to 31%. And the HDL cholesterol increased by 7 to 8.6, and the LDL reduced by 5.3 to 8.6. So this is important, because we are trying to see for the cardiovascular risk factors rather than just the weight loss. So we have understood that there was a visceral fat loss, there was an improvement in the dyslipidemia parameters as well. And then the question comes, what happens if I discontinue? Because this is a question every patient asks. When you tell the patient that I'm going to start you on tirzepatide, the next question which comes, for how long I have to take? What is the time duration? So at the moment, I don't tell them that you have to continue. I tell at least take it for 6 months, we'll see how you do. Then we'll follow you up and decide. So once they lose the weight, they maintain, they may be okay to continue, but sometimes it happens, we know that if we tell them that if you have to continue, they may not be ready. So this is what happens to insulin as well. And that is how we convince most of our patients. We tell them you start, we'll see 3 months, how you're doing, then we'll take a call. So we buy time in a way. So this was a study which they did to find out what exactly happens when you discontinue. And they took patients with, in these patients with obesity or overweight, with obesity-related complications, again excluding diabetes, and this was again a phase 3 study, and they were trying to see the percentage change in the body weight from week 36 to week 88. So what they found, that participants who stayed on the Mounjaro, like from the, after the lead on period to lose weight, versus the participants who regained the weight when they stopped the drug. So total weight reduction in the participants in the Mounjaro from week 0 to 88 was 26% versus 9.5% who stopped taking Mounjaro at 36. So this is the truth. We know the mechanism, we know the science behind that. So the patients are going to regain most of their weight, but we have to also counsel them to continue the lifestyle, because we will have patients who may not be able to continue. There will be patients who will default. So all this has to be, we have to be aware of, and we have to counsel accordingly. Adverse events, if you talk about, whenever we talk about GLP-1, GIP, the first thing which comes to the mind is the adverse events on the gastrointestinal. So we always think, okay, will my patient have nausea? Will my patient have vomiting or diarrhea, or what will happen to my patient? So that is what they have tried to see, and in this SURMOUNT-1 clinical trial data, they found that it had a similar safety profile to other incretin-based therapies, and we know that most of the common side effects were gastrointestinal. There are few tips which we can give to our patients, that after the medication is started, don't try to eat heavy fatty meal, don't go to parties and do binge eating, because this is a common scenario we have seen, that they will go, they'll eat, and then they phone that we are having severe vomiting. So avoid high fatty meals, don't do binge eating, eat lighter, eat the balanced diet, and most of the time they will tolerate. Yes, we have to counsel that this side effect may happen. Some of them may have diarrhea as well, but we have to counsel them, and mostly it subsides. But we have to go slow. We have to slowly escalate the dose. That's how we do. And the similar things, SURMOUNT-4, they have tried to see again the gastrointestinal ones, and they occurred primarily during the dose escalation, is that what we see, and they decrease over time. So we know that when we start it in our patients, initially they will have some GI side effects, but over a period of time, they will subside. But slowly, the patients will start getting adjusted to it. You will have a few percentage of patients who will not tolerate the drug, or who can't tolerate a little bit of the loss of appetite. So that's fine. But the thing is, there will be patients who may not tolerate, so that's a very small percentage. And sometimes when we are escalating the dose and they don't tolerate the higher dose, we go back, we de-escalate and go back to the lower dose at which they were doing fine. That's how we can continue the medication. And most of the times our patients do well, but there are patients who will develop even aversion to smoking, alcohol, everything when they are on this. I recently had a referral from a psychiatrist actually to start Mounjaro for the indication that patient was smoking and was not able to stop it. And the psychiatrist had read and saw a few patients who stopped smoking also after taking it. So this is an off-label thing, but we told no, that's not the indication, that's not the approved indication. If the patient has obesity, yes, we can start it for that indication. But this is just the anecdotal thing which we are getting referrals even for, and we are seeing in our patients. So we know that the weight loss is quite significant, and we count in terms of percentage. Anything above 10, we are still happy, because we know then we will have cardiac, renal, metabolic, as well as the MASLD and the MAFLD benefit with it. And we know that 16% was with 5 mg and 22.5 with 15. But the crux of the thing is that patient has to continue the treatment. So we have to tell that if you stop the treatment, you will probably regain a large percentage of your weight back. The main loss of the weight happens because of the loss of the fat mass. It's not that you're going to lose muscles, but patients will come to you saying that I have lost my muscles, I'm looking very thin, and people are saying, what's happening to you? It's always a good idea to tell the patients about some resistance exercises when you're starting it. I always counsel them, all my diabetics anyways, to do some TheraBand exercises and little bit exercises to continue, because what happens, they'll do brisk walking and they'll think that that's the only exercise, but the muscle resistance exercises they don't do. So we have to counsel for that, and very easy exercises can be taught, which can be done at home by anybody. So those things are important, because that is practically easy then for you to counsel your patients to continue. Otherwise, many a times it does happen that they will like to stop it because others are telling them that they have lost too much of weight. They don't count the benefit, but they count the appearance also. Also, why we are talking so much about weight loss with this drug, because we know that we have the reduction in the cardiometabolic risk factors. As I told you, the blood pressure also reduces by few millimeters. There is reduction of the LDL and the triglycerides, and a small increase in the HDL. So that's what we want. So at 72 weeks, they found that there was a betterment of the cardiometabolic risk factors as well. Also, gastrointestinal side effects are the commonest. Proper counseling can take care of that. Counsel the patient, tell the patient, but we should not make the patient afraid about it, but tell it that this will happen. Most of the time, small amount, mostly you will not have problems, but tell them not to eat a heavy fatty meal. We also have to counsel that these side effects will happen mostly in the beginning few weeks when we are up-titrating. If you have up-titrated, patient gets a problem, de-escalate and continue with the dose which the patient was tolerating. Maybe after 1 or 2 months again try to escalate. This is what we do, which makes patients' compliance better sometimes, and they tend not to default. So with this I end. Thank you.